Good. Let's go. Acute coronary syndrome, one of my favourite topics. Who knows what acute coronary syndrome is? Who's heard of it? It's a fairly new term. Anyone heard of it? Yeah, you all have. What sort of year are you? Can I just sort of gauge what level you are? So who's in their first or second year? No one. Third year? You're all fourth and fifth years. Okay, so we don't need to talk about too much. So we'll have a brief refresher then. So we'll be aware that atherogenesis, if we pop that in the middle there, is a sort of culmination of a few things. And inflammation is very important. We're learning that more and more. Also, abnormal lipid metabolism is very important, the reason we give people statins. And also, with acute coronary syndrome, thrombosis is a major factor, the reason we're giving antiplatelets and things like that. So you'll all be familiar from this diagram from your textbooks, and this is the natural history of atherogenesis. About my age, you start to get things like, well, I'm probably about here, actually. But you start to get things like this, and as you get older, as you get fatter, so do your arteries. Well, you don't have to be fat to have this. And eventually, something happens. And I think that's quite a complicated model, so let's, for today, keep it quite simple. And just call it ABC. So what happens is you've got an atheromatous plaque that then bursts, and then you get clot forming. And that leads to a reduction in coronary blood flow. Bad. And gives you an acute coronary syndrome. Now, acute coronary syndrome is an umbrella term for a number of conditions. So here we've got the ST elevation myocardial infarction, and that should give you an idea about what we're going to go on to next about how to stratify patients. And there's the non-ST elevation acute coronary syndrome, which is made up of unstable angina, where there's been not very much damage to the heart muscle, and an actual myocardial infarction, a non-ST elevation myocardial infarction. So there's those two things there. So ST elevation myocardial infarction and non-ST elevation ACS. Okay, and I'm going to go through things as a sort of practical approach, just from the moment someone comes in through the door, what should happen 10, 20, 30, 40 minutes down the line, all the way up to the first sort of 12 hours of admission, what we should be doing for them. And I'll show you what we do. So clinical features of someone who's coming in, maybe having a heart attack in acute coronary syndrome. So history. So you want to assess with your history the likelihood that you think this pain that someone's experiencing is cardiac, and there are a number of typical features that we'll go through in a moment. Also, you want to pick things out that support the diagnosis. So if they've got lots of risk factors, their father died at 50 from an MI, this patient had one last year, they're a bit overweight and all the rest of it, and they smoke. You also want to exclude differentials. So, that they had a fall last week may be important or anything like that. So exclude differentials. Elucidate the circumstances. This is really important. Where were you when this came on and what were you doing? So if someone says, I was walking up the stairs and the pain came on, and then you ask them about angina and they do get angina on exertion, that makes you think this is more likely coming from a heart, it's more likely cardiac pain. Whereas if they're at rest, it may well be cardiac pain, but you may think it's less likely. You also want to define the context of it. So who are they, what do they do, and what medical comorbidities do they have, and what medications are on. So let's just go through you all heard of S.O.C.R.A.T.E.S, right? This is something you learn, and I'm not sure it's something that everyone really sticks to when they take histories. We probably should, because you do get a lot of information out of it. Especially, I finished nights yesterday morning, and believe you and me, when you're sort of in the middle of a night shift and trying to stick to something like this would be really useful, because you can miss things when you're tired and hungry and cold and alone. So this is really good. So who wants to tell me something about the typical cardiac chest pain? So where do they usually describe it? Yeah, so it's usually central, isn't it? Okay. What about the onset? So what's the types of onset can we have? So we can have a gradual onset. Is it usually gradual onset? No, so it's usually a sudden onset chest pain. Okay. Character. What does it feel like? Yeah, central crushing chest pain. That's what they all describe, isn't it, in the books? But other people can have different ideas about what it is. They can say it's a very dull ache. Some people may experience sharp pain if they've got inflammation of the pericardium or something like that. And always ask the patient, what exactly do you mean by a sharp pain? Because to some people, a very severe pain may be described as sharp. So do ask them, what do you mean by sharp? Did it feel like a stabbing knife, or was it just very severe? So do ask them what exactly they mean by the words that they use to describe it. Because not every patient reads medical textbooks. Some do, especially where Ed works in West London, which makes his job infinitely more difficult, I imagine. Radiation, does it go anywhere, this typical cardiac chest pain? Yeah, left arm's the usual, isn't it? Also goes up to the jaw or the neck. But you can have people present atypically. I met a guy during my last set of nights who had, he came in with a chest pain across his back and really feeling a heaviness in his arms. And that was his feeling of chest pain with myocardial ischemia. And he was a diabetic, and diabetic often do present atypically. Associations, what do you get in association with it? So someone at the back, give me one. Yeah, nausea. Oh, you said that in unison. That's brilliant. Why is that the first one that gets... Okay. Yeah, nausea. They may vomit, but usually not. Anything else? What was that, sorry? Sweating. Yeah, they might be really sweaty. Anything else? Say again? Yeah, they might get pale. So pale, clammy. Someone said something else. What was that? Yeah, shortness of breath, palpitations. So lots of other things that can be associated with, isn't there? And timing. What usually happens if someone's having a heart attack? What happens with the timing of the pain? Does it get better or does it get worse? Usually gets worse, doesn't it? Till the point where they think they need to call the ambulance. But timing is important, especially when you think about the next one, which is exacerbating factors. If they've got a history of angina, this pain will be very related to exercise. So exacerbating factors may be exercise. Relieving factors, if someone's having true cardiac ischemia and they're known to have that before, sometimes glycerol trinitrate may help them. And usually things like paracetamol are ineffective. So you wouldn't expect someone with myocardial ischemia to have relief from simple paracetamol. And severity is usually pretty severe. It's usually very, very painful. Not that I've had one, but I'm told it's actually quite painful to have a heart attack. So that's S.O.C.R.A.T.E.S. Very useful. I suggest that even when you move into your postgraduate career, you do stick to things like this because they are quite helpful. And if your consultant might ask you at 3 in the morning, a particular feature of it, and you may not have asked. So do stick to it. And examination, you're going to want to examine the patient to support the diagnosis. You're also going to want to exclude any differentials. So you're going to want to push on their chest to see if they've got any costochondritis or sternal pain. That makes it less likely that it's cardiac. And identify any complications. So you're going to want to listen to their heart sounds because you can get ventricular defects with, you can also get rupture of the papillary muscles and generate murmurs. You can also get pericarditis and you might hear a pericardial rub. So it's really important to identify those kind of complications. You also want to know if they're in heart failure or not. So you want to see if they're peripherally warm. You want to know that they've got a good pulse. You want to check their rhythm to make sure they're not going into an abnormal rhythm, because the reason people die from heart attacks out in the community, the people that drop dead suddenly, is not from complete myocardial failure. It's usually from an arrhythmia. So ventricular tachycardia is very common, and ventricular fibrillation is very common with ischemic cardiac insult. So do try and identify any complications. You're going to want to listen to the chest as well. Okay, initial management. I heavily rely on things like this. So move, we've heard this before. Ed was talking about this before. So you want to slap the monitor on, and the things you're going to want to monitor are, can you give me one really important one? ECG, yeah. So 3-lead ECG. So you want them on the cardiac monitor for the reason that I've said. You want to know what rhythm they're in. They may go into ventricular tachycardia, and you won't know about it unless they're on the monitor. So that's really important. You want to monitor their oxygen saturations and their blood pressure to make sure their heart's not failing. You also want to monitor other things like their urine output. So think of all the monitoring you can get and put it on them. Oxygen. This is a bit of a controversial one. You probably won't do any harm, and it's certainly been tradition that we do give oxygen people having heart attacks. But I would say probably give them a bit, but if they're not hypoxemic, I'm not sure what the value is, and there's a theory that you may increase reactive oxygen species generation and therefore reperfusion injury. So we may see something in the next year or two come out about that, but there's no evidence at the moment. Venous access, need that? Why? Go on. Say again? Yeah, so I'm going to say this time and time again. If you're going to give someone a cannula, if you're going to put a cannula in, always get blood out. It's your opportunity to get blood out. So anything goes in the patient, make sure you're getting something out of it as well. Take some blood out, because you want to take that off and send it to the lab for cardiac troponins and you know, all the things that we do on patients usually. But also, a lot of the drugs we're going to give, if they do go into VT, we're going to want to give them something like amiodarone. So we're going to need good venous access. We might want to give them, support them, their blood pressure with a bit of fluids or inotropes. So we need venous access for that. They may need morphine is very good, and we'll talk about the initial treatment at the moment, so in the next slide. We're going to need venous access, absolutely, to give them drugs at the moment, but also in case things go wrong. And ECG, 12-lead ECG is absolutely essential, and we'll talk about that in a sec. So here's my mnemonic for, well, it's not mine, I didn't make it up, but it's one I heard, for treating cardiac pain at the bedside. So you're the first on the scene. What are you going to do after you've done your move? You're going to give them morphine plus an antiemetic like metoclopramide, because opioids can be very emetogenic, and you don't want them having a heart attack and vomiting at the same time. That's just a complete mess. And the CCU sister won't like it. I mean, they're on CCU because they like nice, clean, specialty things, and they won't like to see vomit at all. So you have to give them antiemetic. Oxygen, we've already spoken about, big question mark at that one, but if they're hypoxemic, yes, give it to them. Nitrates, so we might want to give them glycerol trinitrate spray under their tongue, or possibly further down the line, we give them a nitrate infusion. Aspirin as well, so that's the A in Mona, so antiplatelets we could probably put instead of aspirin, but aspirin, certainly if there's no contraindication, is very useful. And then we're going to do, within 10 minutes, ECG. And the reason we're going to do that is because it determines what happens to the patient next, and it determines prognosis. And it's going to stratify our patient into one of these two groups, either non-ST elevation acute coronary syndrome, or if they've got ST elevation on the ECG, ST elevation myocardial infarction. We'll talk about this one first. So if I pop up that ECG, probably doesn't project that well. I hope you guys in York can see it. But can anyone point out any abnormalities there? Just have a look at it for a second, and then I'll ask someone when I get my green laser pointer out. Go on, say again. Someone shout. Pop up your hand. Okay. So that lead there. Okay, there's a bit of raise. So with J point we're looking at. So that's the P wave QRS, and this is the T wave. So we've got ST elevation in lead 2, and 3, and AVF. And you're familiar with territories, aren't you? That there are certain leads that look at a specific area of the heart, and you should be able to map out your hexagonal reference and work out where they look at. So 2, 3, and AVF are... Hey? Yeah, so they're the inferior leads, okay? What about these leads here? How about let's say V2, 3, 3, V4, where do they look at? Yeah, the sort of anterior sort of septal parts, don't they? And what about the V5, V6, lead 1 and AVL? They're the lateral part, okay. So here we've got ST elevation in 2, 3, AVF. Anything else to comment on? What are the signs of ischemia? So we already know one, so we've got ST elevation. What about anything else? ST depression, it's a sign of ischemia, isn't it? But beware, if you've got it anteriorly, they may have posterior ST elevation. Okay, do we have any ST depression? Yeah, kind of, yeah. V2, certainly, definitely. V1, just a little bit, yeah. So we've got some reciprocal ST depression there. Anything else? T-wave inversion is the other thing. Do we have any T-wave inversion? Where? V1, yeah, kind of. But V1, that's kind of normal. So if you see T-wave inversion in EV1, that's kind of normal. But kind of not really. There's not really that much. There's not any T-wave inversion apart from, as you say, lead 1, but that can be normal. So I wouldn't get too excited about that. So this patient has got an ST elevation myocardial infarction. If it's associated with chest pain, if the nurse has just done an ECG because they're being admitted, then you see that. I mean, I'd be very wary about sending them for urgent reperfusion, but you need to have it in association with chest pain or some other sign that may think that you've got typical symptoms of a myocardial infarction. And if they have got ST elevation, they need urgent reperfusion. And that is, needs to be done very quickly because time is myocardium. The longer you wait, the more heart muscle dies. And you should follow your local protocols wherever you are. So what are the hospitals that you work at around here? What's the big one? So I don't know. Say again? Hull. And how about you guys in York? You can't speak to me, can you? York District. Okay. You have to look at what they do there. I'm sure you already know already. But we used to do thrombolysis. That's kind of on the back of a couple of Danish studies. Now we're moving to this, primary percutaneous coronary intervention, which is where we stab them either in the wrist or the groin, and we go in with catheters, take an angiogram picture, find out where the culprit lesion is, and we place a balloon inside of it, and we inflate the balloon, squash all the clot and the atheroma to the sides, and then we pop in a stent to hold it open. And you can do that up to 12 hours after the chest pain. So it's still important to consider this if someone's had ST elevation. Okay, so that's what we're doing for that. Any questions on that before we move on? No? York, any questions? Oh, you can't. Here. Oh, never mind. Okay, so non-ST elevation ACS. Let's go through that. So look at this ECG here. So let's remember our three things that we look at for coronary ischemia. So in myocardial ischemia, we look at ST depression, elevation, T-wave inversion. They're the main three. So what can we see on this ECG? Anyone? Yeah, where? Yeah, so AVF, lead 2, and someone's drawn on it, haven't they? Buggers. Sorry, I shouldn't say that. But I mean, I don't like people that draw on ECGs because people like me want to come and photocopy them and show people like you, and it's got horrible biro all over it, and it's not very nice. And you don't need to point things out. You can just write in the notes or on top your impression. And cardiologists get very annoyed about it too because they want to keep it for their ECG collection. But here, they probably wouldn't pick this one actually because this one's bog standard. We've got T-wave inversion in lead 3 and AVF, and we said they're inferior leads. And actually, this is the same patient as the ECG we saw before, just a bit earlier in time. So they came in with chest pain to the hospital, and they were sat there, had an ECG, and we saw this, and we may be thinking they've got a non-ST elevation ACS. And then they developed more chest pain, and their ST segments went up, and we sent them over to the nearest cardiac centre for primary angioplasty. So it's the same patient, just later. So that's really important. And with these patients who have got coronary ischemia, non-ST elevation ACS, you're going to admit them to coronary care, and we're going to do all of our monitoring. So we do our move, and we keep a close eye on them, preferably in CCU if you've got one. And we're going to try and do two things. We try and stop the thrombosis and reduce the myocardial oxygen demand. We can stop the thrombosis by giving them aspirin, clopidogrel, the antiplatelets. We can anticoagulate them with an enoxaparin, which is low molecular weight heparin, or fondaparinux, which is again another pentasaccharide anticoagulant, and sometimes a statin. Statins do reduce cholesterol, but they have lots of pleiotropic effects, and they also reduce inflammation and can be useful in acute myocardial infarction settings. We also want to reduce myocardial oxygen demand, and we can do that by dilating the coronary arteries and the peripheral circulation, thereby reducing afterload with a GTN infusion, which is great. We might think about giving them a beta blocker, because that will slow the heart rate down and reduce the amount of oxygen the heart needs. And that can often be very useful if someone's got ongoing chest pain. And controversial, but not often given, but perhaps should be considered as an early ACE inhibitor. Okay, and then we want to again review them after we've initially stabilized them and monitored them. We want to reassess them and assess their risk. So we stratify them into an intermediate risk patient, or a low risk patient, or a high risk ACS. And there are a number of ways you can do this. I'm not going to go through now. It's probably a bit too much for the time that we have. But if they're high risk, then we want to have early angiography, essentially. And if the pain's not settling, if they've got ongoing chest pain, but their ST segments don't go up, and all of your treatments you're giving aren't working, I think you need to review the diagnosis, try and work out, is this actually myocardial ischemia? And if you think it is, obviously speak with your seniors. But they can send people over for percutaneous coronary intervention if their pain's not settling. Then we want to review them again at a further period, and usually after 12 hours when we have the troponin, because what troponin is a component of cardiac muscle, and there are specific markers of it. And if you get heart muscle die, it releases the troponin into the bloodstream, and we can test it. So from the moment you have coronary ischemia over the next, say, 12 hours, your troponin level rises, and after that, we want to have a look at the troponin. And the amount it will rise depends on whether there's reperfusion or not. If there's early reperfusion, you get a troponin spike much earlier than you would do if there wasn't reperfusion. And if there isn't reperfusion, you get a peak much later, but it's much more sustained, usually a few days. So you wait 12 hours to do that. You can do an admission one just to check, because if the troponin is raised on admission, they've got chest pain. You know, it's probably going to be they've got myocardial ischemia and they're having an MI. But certainly if it's negative, you need to do it again at 12 hours. And from there, if their troponin's negative at 12 hours, but they've had what you think is cardiac chest pain, then you might call it unstable angina. And if their troponin is raised, then you're going to call it a non-aestivation myocardial infarction. And usually we send these people over to have an angiogram, to have a look at their coronary arteries, see if we can identify a culprit lesion, because they're at risk of that happening again, and we can. It doesn't need to go in immediately as in primary coronary intervention, but we'll need to go within the next few days. And that's really it. So that's a sort of practical approach of what you should be doing with acute coronary syndrome. I'm sure you've experienced everything that I've been talking about on the wards yourselves. Are there any sort of questions that you wanted to ask? No? Okay, brilliant, that's good. How about you, York? No? I'm going to hand over to Ed now. What are we doing next, Ed?
Arrhythmia.
Arrhythmia.